Thank you, Melinda. I'm excited to be a part of this transformational effort to create a coordinated and structurally connected community of care for older adults with complex care needs. What we've heard this morning resonates with what Area Agency on Aging and community-based organizations and service providers experience every day in our work to help older adults and persons with disabilities live healthier, more independent lives in the setting of their choice. Increasingly, people with complex care needs say they want to age and receive needed supports and services in their own homes and communities, especially in light of the pandemic. But a wide variety of barriers stand in their way, including unidentified and unresolved social determinants of health issues, fragmented systems of care, and payment models that don't support home-based or social care. Partnerships to structurally link medical care and social support teams and innovative payment models can have significant impact in reducing emergency department visits, hospital readmissions, and nursing home stays, and make living healthier, more independent lives possible for older adults with complex care needs. Transitioning from problem-based healthcare to personalized health and social support by bringing together medical care and community-based clinical teams can have significant impact toward meeting patient-identified goals, and that is our transformational aim. Here to talk with us about a framework for integrating health and social care is national thought leader and health and social care integration expert, Robyn Golden. Robyn is the Associate Vice President of Social Work and Community Health at Rush University and co-director for the Center for Health and Social Care Integration and the Center for Excellence in Aging. Please help me welcome Robyn, joining us from Chicago.
Good morning. Thank you so much, Christine. What a wonderful introduction. And I've always wanted to visit. I always want to visit to Southwest Michigan, but now I think I want to live there based on the incredible work that you're doing. So I can't say enough. And Ira was amazing, and your work is incredible. So let me talk a bit about what I want to cover today. I want to talk about the 5 A's, which come out of the National Academy of Science, Engineering, and Medicine study that we'll spend some time talking about together today. I'm also going to highlight various examples of initiatives across the country working to improve health and well-being of older adults and family caregivers by innovating and making healthcare delivery more responsive to social needs through cross-continuum partnerships, just like you're doing. And throughout all this, I'm going to just call out opportunities for action for all of us as diverse providers and community members to reinforce this incredible complex care work that we're talking about today and the care continuum related to it. So what brings us here today? As we look ahead, Dr. David Blumenthal, president of the Commonwealth Fund, has said, it will be necessary to address an individual's functions, social, and behavioral needs, largely through the provision of social and community services that today are not typically the province of healthcare delivery systems. Our imperative for this and beyond is to identify areas of opportunity to integrate health and social care across settings. We all know that healthcare needs to be improved on, so much so, although you're doing a pretty good job in Southwest Michigan. But in order to be more comprehensive in addressing this, we have to look just beyond just clinical or physical health issues, as Dr. Biak said. But we also need to be more responsive to the psychosocial, economic factors that influence health as well. As this pandemic has amplified our country's needs to collectively moving upstream to address discrimination, poverty, and dangerous environments that we know fuel inequitable outcomes, will also are also critical in being attentive to and caring for those who experience downstream needs now. So as we've seen in recent years, social determinants of health have taken center stage in health and health policy discussions. It's funny, for some of us, we've known about, social determinants of care for our whole careers, particularly I as a social worker, that's what we were all about in our learning, but the world has discovered it in a whole different way. And so much of it has to do with the growing focus on global payment, accountable care organizations, and other initiatives focused on population health. But the increasing recognition of psychosocial and economic issues as causes of illness is really important and has the power to improve older adult health as well as all age folks' health, as well as create new opportunities, though, for the field of aging. As you can see, this is a very increasing attention to the social determinants health is also happening at a time that we as a generation of older adults is growing, and we will be more diverse than ever before. It's a generation with more education, increased longevity, more widely dispersed family, and more racial and ethnic diversity, making the needs for services much different than those of previous generations. We also know that poor health disproportionately affects older adults, not only because more illness occurs in late life, but because illnesses accumulate over a lifetime. So if we look at some of the characteristics of the Medicare population, and you know this as well as I, we're talking about 30% of Medicare beneficiaries have 5+ chronic conditions. And this is the fastest growing segment of the Medicare population. 36% have multiple functional limitations, which of course can be as critical as the medical issues they face. 34% have somewhat of a cognitive or mental health impairment. This correlates, of course, in our government standards to high cost and utilization rates due to hospitalizations, intensive care treatment that are all often preventable and not always aligned with the individual's preferences. A sign that the system, our system, is set up inappropriately, and that the needs of the older person extend beyond the care of their physical ailments to social and behavioral needs, which are centrally important to their overall well-being, is what's getting reinforced today over and over again. We're seeing a lot of attention from the industry folks looking to disrupt healthcare, whether it's CVS or Walmart or Amazon. Some of these specific examples are a few years old at this point, but the same trends are continuing to happen today. And you can see they're all making a difference. Our CEO at Rush kids around and says, you know, the future of healthcare is in the Walmart back corner. And he may indeed be right. So you have a sense of all of what's going on, the use of Alexa, all the different things that are going to go on that are going to disrupt the way we view healthcare. Some of that may be positive disruption, of course. So, as I said, social determinants, and I kind of kiddingly say everything old is new again. And they're defined by the World Health Organization as conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping their conditions of daily life. This recognizes that the psychosocial and environmental factors are root causes of poor health and can lead to the exacerbation of physical symptoms, chronic conditions, weakened immune system, depression, and anxiety, and greater difficulty following the clinical plan of care very often. And again, higher costs. There is a need to look beyond some of the traditional and social and economic factors that we often think of. So I want to add things such as age, and particularly the concept of ageism, caregiving status, whether or not someone's a family caregiver or there are family caregivers, as well as cognitive and mental health status. And then a newer one has to do with social isolations, which we can't talk enough about these days. So these factors, I believe, are additional components of social determinants that relate to older adults in particular, but even more broadly, we can talk about across the population. So we also know that these factors result in inequitable outcomes in health and life expectancy. The unfair and avoidable differences in health status that are so prevalent in our city of Chicago and our country in general. We can't stop talking about this. And thank goodness for sad reasons that COVID has ripped the Band-Aid off of this one. But if you look at just across the United States, zip codes are often better predictors of an individual's health than their genetics, which we see playing out on the west side of Chicago where I work through gaps of life expectancy of 12 years. So most of you, based on where you live, have probably been to Chicago. And if you look at the Loop, which is the downtown fancier Michigan Avenue area, the average life expectancy is 82. Then if you go west, 6 subway stops to around where I work, the average age life expectancy drops to 70. Can you imagine 70? And then when you go a little further west to the first suburb, of course, has a fair amount of money associated with it. You go back up, people go back up to living to age 82. This is what we call the death gap. And it is unacceptable to see, and something that I know that we're working hard to try to balance and help people thrive and live much longer lives, because their lives are shortened for reasons that they shouldn't be shortened, and much less have to do around chronic conditions and medical care, and more have to do with the social aspects of what's going on. So again, reinforcing the conditions in which a person lives and work account for so much in terms of improving their health care, and particularly around prevention, which is often not talked about enough. So despite the growing understanding of social determinants of health, our society still places a strong emphasis on self-reliance and perseverance. These values in our society contribute to the myth of healthy aging, and that one's choices over the lifespan determine their health and well-being in older adults. This is often what I call blaming the victim. What we know is that these social determinants accumulate over the lifespan, and it is much less about one's individual choices around health and well-being, and more around equitable access to healthy choices and lifestyles. If we don't, we have a health legacy program out in the church basements in our primarily African-American area of Chicago on the west side. And they have food deserts. So when we're talking, we do a big piece around, well, how do you compare when you pick up your dinner for very low price at a McDonald's that serves your family of 4, the Happy Meals, to a chicken, rice, and green beans that we try to show could be comparable price-wise. That's a really nice notion, but do they have access to that chicken, rice, and green beans? Not always. So we have seen this loud and clear during the pandemic, as highlighted by Dr. Fauci several times. Systemic racism has long perpetuated unfair disadvantage among our Black and Brown communities, including economic instability and a higher prevalence for underlying medical conditions. Then the pandemic came, and these very communities were more likely to be essential workers and unable to safely distance from one another at home or in the community, or take sick time if exposed, while also being more likely to having underlying conditions. And to bring up again, the being Black and Brown in our community is enough risk just due to racism. And then adding age on top of it makes it what I call a double whammy that we must keep in mind in terms of enabling equity among the older adults we serve. And this quote from the World Health Organization is a good one. The conceptual framework for action on the social determinants of health sums it up well, that one can say that health enables agency, but greater agency and freedom also yield better health. The mutually reinforcing nature of the relationship has important consequences for policymaking. So let's talk a little more deeply about what it means to rebalance healthcare and what has been shown to make a difference. If you look at Elizabeth Bradley's work called The American Healthcare Paradox in her writings, it's the higher healthcare spending is not translated into improved quality and outcomes. We spend a heck of a lot on healthcare and don't necessarily get the outcomes in this country. And I'd like to suggest, as she suggested, or reinforce, it's not that we're spending way less overall, it's that we're spending way more on medical care than on social care. And that medical care spending has a percentage of the GDP is much higher in the US than in other countries. So that explains then why our less of an investment in social services and integrated care initiatives are causing it to not pay off for us. But I'd like to suggest it would pay off in the way that you're beginning to think about it in Southwest Michigan will make such a difference. In 2016, an analysis of 39 studies of investments in social services found that the majority, 82%, had significant positive effects on health outcomes and healthcare costs. The biggest impacts were in housing support, income support, food insecurity, and care coordination. But funding gets in the way, and the Older Americans Act funding is so small compared to what I call the 800-pound gorilla in the room, which is CMS, Medicare. Just think about it. The Older Americans Act covers services like home delivered meals, caregiver respite. It's gone down over time or stayed the same. It doesn't connect with what inflation is all about. While Medicare's budget continues to grow, and Medicare has not even considered reimbursing for what we're talking about today is more of the social care elements that are critical to people's lives and well-being and overall health. Just to reinforce, people live in communities, not in hospitals. So funding needs to reflect that. You can see, so tell me, Doc, what do I need to improve my quality of life? A new hip? And the physician says, a new government. So this is kind of just a tease, but really quite truthful. The aging field will only grow if it's considered part of the medical budget. I too had a health and aging policy fellowship many moons ago in DC. And when I realized, I went with the intention of how do I learn to better serve older adults from a policy lens? And what I learned is that most of the money for older adults, the potential funding sits with CMS, certainly not our traditional Older Americans Act. So how do we undo that? But if you look at our health and human services, there's been much more of a focus on the health part and less on the human part. So aging services funding will never meet the demand as things continue on unless we do some potential rebalancing, which is so unfortunate that the social and aging services are so critical to fill this divide that we're talking about. And the result ends up being not addressing social determinants, which is there's no treatment, there's a decline in health and functioning, hospitalization, increased institutionalization, unmet psychosocial needs, and older adults and caregivers suffering and unnecessary healthcare costs. All of these are potentially preventable. We must do better for our older adults. You know that better than anyone. So healthcare's blind side, I'd like to talk about a little. In a 2011 RWJF study, 1,000 physicians were surveyed, family care docs. And 86% of them said that unmet social needs directly lead to worse health conditions. That 85% say social needs are as important to address as medical conditions. That 80% were not confident in their ability to address those social needs. And that 76% wish the health system would cover the cost associated with connecting patients to services that meet their social needs. And that if they were able to write prescriptions for social needs, 1 out of 7 prescriptions would be indeed for those needs. Yet they didn't feel equipped, they didn't feel they had the time or the skill set to carry out these activities. And then a 2017 study reinforced the same thing. So this is what we call healthcare's blind side. And it also brings up the wrong pocket problem, as well as asking what care models and workforce are needed to enable healthcare to be more responsive, whether directly addressing hunger, with food delivery, aligning resources by building collaborative referral partnerships, or advocating for more governmental investment in and streamlining enrollment to programs like SNAP. All of that needs to happen. And this is what we refer to as healthcare's blind side. And hence, here comes the NASM report that I mentioned. And it's again, was a National Academies report. And how it all came about was pretty interesting. I had been observing the future of the nursing report for many years that came out in 2010. It is the most downloaded National Academies report in the history of humankind. The National Academies is kind of like the good housekeeping seal of approval. It's bipartisan, it's neutral. They develop reports. This is where the reports came from, like the importance of hand washing, how do you reduce errors, all those kinds of things come from National Academy reports. So some of us thought, how the heck can we get a National Academies report to speak more to what we're talking about today, social care, and in particular, we were looking to reinforce the role of social work, just like the other report around nursing was reinforced. So to address the blind side, we coalesced the field. We brought together a group of folks who were very interested. We raised a lot of money. It cost $1.3 million to have one of these reports done. And in some ways, it was the easiest fundraising I've ever been engaged in. It was kind of amazing. People really want to give to these reports because they think people listen to them. I was worried that we wanted to get this report done, but we didn't want it to sit on some shelf and get dusty, because that can happen too. So we worked with the aging organizations, social work organizations, and the official charge was an ad hoc committee. You can read it up there. That was the charge of the group, to try to integrate the services addressing social needs and the social determinants of health into the delivery of healthcare, and to achieve better health outcomes and to address major challenges facing the US healthcare system. So it took 18 months to look at this, and it was very intense. I had the privilege of being on the group. There was one person other than me, well, two people, really, one academic looking at two academics looking for more of an aging lens, but most of it was, there were physicians, there were nurses and policymakers, but not a whole lot of us in the aging field, sadly, or even social workers. But it went forward, and the committee made recommendations on how to expand social care services, better coordinate roles for social needs care providers in interprofessional care teams across the continuum of clinical and community health settings, and to optimize the effectiveness of social services to improve.
Robyn, we've lost your voice.
Got it now?
Yes.
Sorry. Feel free to download the this report in any way if you want more detail, but let me tell you a little bit of the administrative complexities present challenges. The committee recognized that while there's a lot of promise to health and social care integration, that various administrative complexities present challenges to this transformation being effective and sustained, and that expanding healthcare beyond traditional medical settings would require health system administrators, practitioners, researchers, and policymakers to expand their emphasis on healthcare delivery to include social care. And that medical models, as Ira said so clearly, were not designed around social care provision. So we had that, there were financing challenges, that when something is saved in one area, like in the community, the people that get credit for that are the hospital, even though the community should be getting credit for that from a financial perspective. All of that is very true and needed to be rebalanced. And then the workforce needs were incredible, that who is the workforce to provide social care? And let's make sure we don't recreate or think that physicians, even though it's important for the relationships, should be doing all of this, that it's critical that it's a team, an interprofessional team. So we'll talk a little bit more about that. What came out of the study were the 5 A's. And the 5 A's have to do with awareness. I'll go over that one first. These are activities that identify the social risks, needs, and assets of defining patient populations. And if you're thinking about transportation, let's use that as an example. Awareness would be simply asking patients if they have a way to get to their appointments, the grocery store, and other places that they need to be healthy or improve their health and well-being. Or it could be conducting research about transportation gaps in your community. Adjustment are activities that focus on altering clinical care to accommodate identified social barriers. Here, for the transportation aspect, it's to reduce the need for in-person healthcare appointments by using other options such as telehealth appointments. Now, I wrote that long before COVID, so you can see how that's even probably more significant now. Assistance, the 3rd A, have to do with activities that reduce social risk by providing assistance to connecting patients with relevant social care resources. This is like providing transportation vouchers, coordinate rides with volunteers so that patients can travel to healthcare appointments as an example of that. Alignment has to do with activities undertaken by healthcare systems to understand existing social care assets in the community, organize them to facilitate synergies, and invest in and deploy them to positively affect health outcomes. So an example here is to invest in community ride sharing or time bank programs. And last but not least is advocacy, in some ways the most critical for all the rest to happen, in which healthcare organization or social service organizations, aging network, promote policies that facilitate the creation and redeployment of assets or resources to address health and social needs. So the transportation example here would be to promote policies that fundamentally change the transportation infrastructure within the community. Not easy, but it can be done. So these were the consensus goals after 18 months we came up with many detailed recommendations beneath them. And as we know, COVID has related to our, we've seen our societal inequities have been magnified, and it's been more imperative than ever to bridge the gap between social and health needs. And based on the committee's findings, we talked about designing a healthcare delivery system to integrate social and healthcare, put the 5 A's into action, that's what we called it, build a workforce to integrate social care into healthcare delivery, develop a digital infrastructure because interoperability is key along the care continuum. Let's face it, it's absolute key. And it's a big challenge between community organizations and healthcare systems, a big problem. So I wanted to, and then the funding piece. How do we work around the funding issues that I've talked about thus far? So I want to just mention a couple innovative solutions in the time I have left. And I know I don't have a lot of time, but I'm going to try to mention a few. So awareness would absolutely be trying to create screenings. And some people have looked at universal social determinant screening, some have not, but at least asking the questions are critical in being aware. Now, for many of us, we're asking these questions, but we don't want to create a situation where we ask questions and don't necessarily have the answers to them. So this is critical, but also there needs to be some structure to answer the needs of people who we're identifying that they have needs. Adjustment, there's a great program in Northern California, and you'll get these slides. It's called Care Neighborhood. And it has community health workers who are embedded into medical home teams with the support of social workers and nurses. And they use a combination and an algorithm to try to figure out who needs the most help around social, medical, and behavioral issues. The pilot was originally in 8 community health centers with 12 CHWs across the care network. And it's worked very well. And these embedded CHWs as part of primary care has really fleshed out the team and done a really incredible job of integrating some of the behavioral and social care needs that we have. Assistance has to do with a great program out of San Diego, 2 California examples. where San Diego has a 211 information helpline where anyone can call, and they have a technology platform where they identify resources and they allow multiple health and social service providers to be part of it. And it's like a 911, but it's called a 211. So it's very interesting in terms of that. And they have an interesting platform that is pretty highly developed around that interoperability piece and exchanging information across the community. So, you've probably heard of a lot of these systems, whether it be Now Power and Bertha's or whatever, but they're using a one that they've created on their own. What's critical about all of this is that, as you can see what Maya Angelou said, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And I think no matter what A we come up with, that's the take-home message today, is that it is about that relationship. And, you can't make a business case for compassion. And I have learned around business cases, I never knew so much about business cases or return on investment. These are hard things to quantify, yet we have to keep striving to do so because we make that difference. Alignment, an A example in the western suburbs of Chicago, one of our wonderful agencies has created a community response network where it's a social safety net, if you will, a connection between the hospital and the social service agents, very similar to what you're doing. Yours is up a notch, though, from what they're doing, but it's been working quite well. Another alignment, very important, and you've been part of this, is out of N4A, the National Association of Area Agencies on Aging. They've developed an Aging and Disability Business Institute, which is critical. As Lynn knows, being a AAA, how do you get to the point where the hospital, now Spectrum sounds very unique, but you are not like every other hospital or health system that we've encountered as we've tried to develop relationships across the country through our bridge model, where we've helped agencies like yours go into hospitals and say, we are that system of care. We're what you need to buy. Don't build your own, to look at a continuum of care. So the Disability Institute has really developed best practices, and I know you're one of them, to help other AAAs also be able to contract in that way. Because sometimes if you don't come together, a lot of healthcare systems will never understand. I mean, part of why we started our bridge model at Rush is I never felt that our discharge planners ever knew anything beyond home health care. And they didn't know the full range of community-based organizations. So that's the value of this. And then I just want to say the importance of advocacy. There was a great program in, again, California, in Marin County, where they really engage the community to advocate for the things they needed. And number one was housing, mobility was second. You see the order, you're not surprised by that. And social connection was a very critical aspect too. There's other aspects in the report that talk about funding too. And there are codes that exist that we could be utilizing for both screening and then doing these kind of care management sorts of activities through that don't get paid for very easily by AAAs and community-based organizations. So we need to rebalance that and advocate for some of what we're talking about in this, which are health and behavior codes are an example of those, chronic care management codes, transitional care model codes that could actually be dropped and allowed by the system to be, for the social service agencies, aging network, to get paid for that work, not for the work to then get paid for and the money go to the hospital when other people are doing the work. So very important advocacy issues. So I just want to end with our call to action. We know that the Aging Network is poised to keep addressing social determinant needs through all the programs you have and more. And while also expanding your reach by partnering with healthcare entities and being hubs for a variety of home and community-based services in the community are critical, along with the nutrition programs, transportation, evidence-based programs, social isolation. Now that the healthcare sector has recognized the importance of addressing related social needs, AAAs are entering into partnerships like you are. And in a 2018 study done by N4A in the Scripps Gerontology Center, nearly 44% of AAA respondents reported having at least one contract with a healthcare entity. So this is happening. It's not happening as quickly as you're doing, but it's critical. And I can't reinforce it enough in terms of this is our bailiwick, and we need to keep pushing on that. And cross-sector partnerships are critical. The National Academy study calls this out, nodding to the importance of effective partnerships, as well as the challenges of operationalizing them due to power imbalances and how hard it is to build a business case to continue referral partnerships. But we have to study it and show the value, as you've begun to do, and showing incredible evidence. These are what I think are our evidence-based care management practices that you all know well. And how do we continue to reinforce that what we do is as much a science as an art? It's critical to articulate what you're doing that's making a difference in order to study it and to show it's not just good enough to say you're part of the team, but what is it that you bring to the team? And the best way to do that is to actually protocolize and study the elements of what you bring. And, you know, it's all of those things. It's the rapport, it's all of the person-centeredness, all of what we're talking about that make that difference and aren't studied enough. So that kind of service research, health service research has to be done in this area. And I just want to end with something that came from Alterra, which is so interesting. My colleague, Joanne Lynn, she talks about get what we want and need in frail old age, what an affordable cost will be, really has to do a lot with better caring communities. And she's done a lot of work around those. And this is the challenge. This is where we have hope, though, too, that we can make a difference in our communities and our world. People have accomplished many seemingly impossible things. So even though we face many obstacles and are in the midst of major changes in healthcare delivery and payment structures, there's also a sense of renewal and hope for the challenges ahead. Going beyond institutional walls where people live to solve complex problems is the prescription for success. We need greater attention to what matters to older adults and their family caregivers. Even though our world is much more complex one than we confronted even a year ago, and many of us have been around for a while, our field must continue to reflect the moral imperative to correct the disparities, enhance equity and equality, and bring us all closer to a just society. Let us all go forth as leaders. May we know our impact, continue our good work, and make sure those we serve get what they want and need as they age. Thank you. Ending with a quote that I think is an important one. Knowing is not enough, we must apply. Willing is not enough, we must do. So there's one question that I see. Could you say more about including family caregiving and social isolation as social determinants of health? Absolutely. Family caregiving has been under-recognized in so many ways that family caregivers, it is so clear that no one asks them how they're doing, what they're doing. They are the de facto system for long-term care in this country, but no one ever says, what can we do to help you? Or are you ready, willing, and able to do this work? So we've been trying to not only recognize family caregivers in our work at Rush, but we've developed a system to address their needs, to help assess what's going on, help them if they have very medical needs that they're expected to do, make sure they know those needs through a teach back clinic. care planning meetings. It's called our Caregiver Initiative, which has just been funded by the John A. Hartford Foundation to go national to be part of the age-friendly health systems movement. So it's very exciting that, that's going to be part of what we do in trying to address what the needs are. In terms of social isolation is equivalent in terms of healthcare outcomes as smoking 15 cigarettes a day. We finally have that in our midst to know those details and what does that mean. It's just an amazing time to look at both of those. Then there's a question, can you talk a little bit about creating a common language for professionals from different systems and educations on care teams to improve communication and trust? Great question. I think the more the team gets together and asks that question among themselves, the better. I don't think there's any application that we can put that language onto any team. I think the idea would be the team organically come up with the answer for that, to figure out how they best know how to cue each other and who does what on a team and what that common language could be. But that would be it. That's part of the norming, storming, whatever, which goes on with any sort of team. Any more questions? I think there was a question. I think that was it. Anything else, Lizzie, that you see? Oh, I see. How could you balance CMS funds with Older American Act funds? Well, I would ask the Center for Innovation, a part of CMS, to do more of a collaborative demonstration to study exactly what you're doing in Southwest Michigan on a broader scale, to say that this is the innovation, the kind of work you're doing. Let's study the impact nationally, and then be able to prove the value of it, the value add, and share some of the dollars that are at CMS to pay for these services, and to share in the wealth, not so much wealth, I'm kidding, spectrum, but be able to share in some of the cost savings and then revenue sharing in order to make that difference. But I think a CMMI study of a larger level from the Innovation Center would make that difference between CMS and ACL, AOA would be critical.
Thank you, Robyn. Your vision casting of the moral imperative to address the social determinants that influence unfair and avoidable health differences in status for older persons with complex care needs resonates with the aging health equity and policy work going on in our region. Further, your insights into the benefits of the integration of medical and social care and the policy opportunities and reimbursement models to support that work reinforces that none of us can accomplish this alone. It will take an all-in approach. But the role and opportunity for community-based organizations to have key impact is clear. We've heard today that there's increasing evidence that community-based services such as access to nutrition, housing supports, and transportation, and more can prevent, delay, or mitigate unnecessary and costly healthcare episodes. Addressing the social determinants of health is a core competency of Area Agencies on Aging and its network of service provider community-based organizations. Area Agencies on Aging, or AAAs, as you might have heard us called, are the organizations charged through the Federal Older Americans Act with developing a coordinated system of services to meet the needs of older adults. More than 600 AAAs operate across the nation, 16 in Michigan, covering all of the 83 counties. AAAs and community-based organizations are deeply rooted in their communities and provide critical supports that serve older adults, caregivers, and persons with disabilities. We engage in outreach and the provision of person-centered, culturally appropriate care to ensure diverse elders are reached and health disparities and inequities in access to care are addressed. To that aim, the Area Agency on Aging works from individual to systemic impact. On an individual level, community-based clinical teams of nurses and social workers whose expertise lies in identifying the unique social risks, individual needs, and even the assets of older adults, and utilize a whole person approach to create person-centered goals and plans of care that capitalize on those social support assets and tap into the wide array of community-based services to overcome barriers and meet those person-centered goals. These community-based clinicians are bilingual and bicultural in that they speak the language of both the medical and the community-based worlds, translating for health partners the view of the home and social environment, including barriers to improved health, and assist older adults and caregivers to understand and act on medical advice and connect them to relevant social care resources to meet their needs. A compilation case example here is a local adult who was a high utilizer of the emergency department. Skilled care in the home was ordered post-discharge, but always refused. A cycle of ED visit, hospitalization, and then discharge to home, only for the patient to experience health decline and return to the ED. That pattern was established and repeated, often many times a month. So a referral to a AAA care management nurse was placed, and it resulted in multiple calls by that community-based nurse, calls to the patient to establish rapport and build relationship. Finally, permission was granted for a home visit, but only on the porch. After 3 porch visits by this nurse, trust was established, home entree was granted, and the primary barrier to improved health was identified. The home was infested with bed bugs, and the patient didn't want healthcare providers or any other assistance to come into the home. Gap-filling funds paid for pest eradication, skilled care in the home was initiated and accepted by the patient, as well as wraparound community-based services such as nutrition support, chore and personal care to meet the person-centered goals of the patient. The result? Patient health was stabilized and the cycle of frequent ED utilization was ended. Now, while pest eradication is indeed costly, and 3 visits by a nurse to build trust and gain in-home access is a significant investment, when compared to the cost of just 1 avoided ED visit, the value proposition for supporting home and community-based services and addressing social determinants of health is clear. The network of local community-based organizations providing these in-home and community-based services are often the daily, boots-on-the-ground partners in care. These community-based service providers have a unique line of sight to the emerging barriers or changes in health status or social support needs and are an invaluable part of the whole person medical and social care team. On a systemic level, AAAs are charged with assessing community needs and developing area plans and partnerships to address those needs. This road to transformation strategy that goes beyond referrals and relationships to structurally connect a community of care, this is central to that systemic level change work. We at Area Agency on Aging greatly value our partnership with Spectrum Health Lakeland and its commitment to creating a community where both the social and health needs of older adults are addressed through a health equity framework and a health and social care integration strategy. To look at that change imperative through a data lens, please help me welcome Debbie Lull, Chief Nursing Officer of Post-Acute Care at Spectrum Health Lakeland. Welcome, Debbie.